Without further ado, we'll get into the topic for the day. The first few hours today are going to be devoted to stroke. Stroke is something that Saifuddin Mola discussed or did dua for during Laylatul Qadr Wasila this year. So we thought we would discuss it a bit this morning, and we're going to be looking at it from a different angle, which is cardioembolic stroke, strokes that originate in the heart but end up in the brain. Our first speaker is going to be talking about a technology which is near and dear to my heart, no pun intended, which is an emerging technology used to combat cardioembolic stroke in patients with atrial fibrillation. I'll let him talk more about it. I won't say any more here. Dr. Murtaza Bharmal from Orange County Hoag Heart Institute, I believe, correct? Providence St. Jude Heart Institute, excuse me. We'll be speaking about percutaneous left atrial appendage occlusion. And if that sounds like a mouthful, I'll explain exactly what that means in a second. Welcome, Dr. Murtaza.
Thank you, Amir Bhai. Bismillahir Rahmanir Rahim. Good morning, everyone. I've been sort of tasked with starting the morning with a somewhat heavy topic. As a quick show of heads, who knows what AFib is? Okay, good. Who knows what this device is? An appendage occlusion. Okay. So maybe 20% of the room. Okay, so we got some work to do. No disclosures. I'll start briefly. We'll touch a bit on what AFib is and the current knowledge we have with AFib, and then get into basically the device that has the lion's share of this left atrial appendage closure procedure, which is the Watchman device. That's the brand name device for the Boston Scientific company. There are a few other left atrial appendage options, but this is definitely has taken the main stage over the last, I would say, at least 20 years now. We'll go into some data as to why it's so beneficial. What is the purpose of the Watchman? How does it help people? And then how do you find the right people, patients that would benefit from the Watchman? In terms of AFib, as a brief refresher, it's an independent risk factor for stroke in many Americans, and at least in the US, upwards of close to 12 million plus people will have AFib. Okay, and we know that in people with AFib, they have a higher risk of stroke, 5 times increased risk of stroke, higher likelihood of recurrence of a stroke in people who already have had the first stroke. And in people who do have strokes, 1 in 6 of them have AFib. So AFib definitely is a main player here when you're trying to minimize stroke or prevent stroke. In terms of the atrial fibrillation-related strokes, definitely number one, higher risk of disability when it's AF related or atrial fibrillation related, higher risk of mortality and higher risk of major disability. So definitely a topic that we got to pay attention to. When we look at the current literature, to put it briefly, we can't talk about cardiac disease without mentioning trials and guidelines, unfortunately, because it's probably one of the most heavily researched areas in medicine, cardiology. And when we look at the most recent guidelines in the 2023 guidelines for AFib, oral anticoagulation is a mainstay of preventing stroke in patients with atrial fibrillation. What does that mean? The 3 main drugs people may have heard of, apixaban or Eliquis, rivaroxaban or Xarelto, and then the last one less commonly used, but probably the most affordable, dabigatran or Pradaxa. Those are the 3 mainstay drugs that are commonly prescribed to minimize the risk of a stroke. When it comes to determining which patients need blood thinners to benefit or minimize the risk of stroke in atrial fibrillation, we have certain risk scores. And to put it briefly, this is one of the risk scores, a scoring system called the CHADS-2-VASc. The reason I mention this is it's going to come up multiple times throughout the rest of the next 20 minutes. But it's a constellation of multiple comorbidities or other risk factors that increase a person's risk of stroke. So if you look, starting on the top left here, I think I have a pointer here that I can use. Not as well. How about the mouse? No. If you look at the top left, so things that increase the risk of stroke, heart failure, having high blood pressure, a certain age, diabetes, prior ischemic strokes, TIAs, thromboembolism, having known vascular disease like heart attacks or peripheral artery disease, and then as well as gender as a category. In addition to talking about increased risk of stroke, we can't talk about that without mentioning bleeding risk, because when we take a blood thinner, certainly the bleeding risk increases. There's a score that's commonly used in practice. It's called the has-bled score. Similar idea, a certain constellation of risk factors that increase a person's risk of bleeding. And usually it's a combination of these two things, the risk of stroke, using this CHADS-VAS score, and comparing it to the risk of bleeding, using the has-bled score. It's a common conversation we have with people. So in the office, someone comes in with AFib and they need anticoagulation. We first determine the risk of stroke, then they determine the risk of bleeding, and then just have a conversation with people about whether a blood thinner is warranted and whether it's something they would want to take. Despite the evidence showing that blood thinners reduce the risk, there's a good number of people out there, almost close to, if you look at the bottom right number is an important one, 40% of people who should be taking a blood thinner don't take a blood thinner. So that tells you a lot, that even though people have AFib and an increased risk of stroke, up to 40% of people aren't on any protective mechanisms to prevent their risk of serious strokes potentially. Taking a step back and understanding, okay, why is stroke risk increased in people with AFib? And I'll show you a picture here on the screen here on the left, on the right, your right. What you can see is this is a picture of the left atrial appendage. That is a part of the heart that's now sort of considered a vestigial organ, plays more of a role, our understanding is in the embryologic development, and as we get older and grow, it doesn't have a significant role. But this left atrial appendage, the knowledge currently is that what happens is when someone has atrial fibrillation, the top chambers of the heart are quivering and blood flow is a little more stagnant as opposed to free flowing. With that more stagnant blood flow in the top chambers of the heart, that increases the risk of clot. That's where blood can coagulate. And in this particular chamber, the left atrial appendage, there is a clot that can form there, and if that clot dislodges and goes anywhere, particularly the brain, that can lead to obviously a stroke. So cardioembolic stroke is what this refers to here. And that's the leading sort of educated, mechanism we have right now. Because we know that there's some people who have AFib who are actually in a normal rhythm because it comes and goes and they still develop stroke. So, but 90% of the time it's cardioembolic in nature originating from that left atrial appendage. And so with that in mind and some of the data which we'll touch on briefly, the guidelines say that there is an option for occluding that appendage in a very sophisticated way, which we'll go into. And that was the beginnings of this left atrial appendage occlusion device, okay? This is an overview of all the different ways to close that left atrial appendage. Again, it's on the left side of the heart, the top part, next to the atrium. It's a small vestigial organ. There's different shapes for it. It's commonly described as a chicken wing. And if you can see here, there's a lot of different ways to treat it. The top two are surgical approaches, where surgeons can clamp or sort of suture off that left atrial appendage. The one on the top right is a combination of going inside the heart and outside the heart. And all of those bottom four are ways to plug or occlude that left atrial appendage by going inside the heart. The one that we're going to focus on again, that takes probably the lion's share of this procedure, is the Watchman device. So what is the Watchman device? It's a procedure, it's relatively what we consider non-invasive, doesn't require open heart surgery, relatively safe, and we'll go through briefly the numbers. What happens is you go through usually the groin into the femoral vein, you insert small catheters, they follow up through the vein, they go into the right atrium of the heart because the veins connect right to the right atrium. You go across the septum, do a transseptal puncture. Once you're in the left atrium, that's where you can get access to the left atrial appendage, and that's where this device is deployed. Through a catheter-based system, where once you extend the device beyond the catheter-based system, the device or the Watchman will self-expand and occlude or plug up that part of the opening of the left atrial appendage. Then in time, ideally 45 days to upwards of 6 months, that device becomes one with the body. The skin will grow over it. You'll endothelialize that vessel or that appendage, and then eventually it should ideally look like this picture in number 5, or sort of a plugged off area that once was open to the appendage. It's a permanent implant. It can never be removed. It's minimally invasive, as I mentioned, and most people can have it outpatient, which means they come in, they have the procedure to go home. The procedure itself, anywhere from 30 minutes to an hour, from start to finish, going into the hospital to leaving, you could say probably most of the day. Most of the time is in the setup and getting the anesthesiologist and all those things. The procedure itself can be done in 30 minutes. In terms of the Watchman, there's been a few iterations of it. It started off as a Watchman 2.5, which was approved initially in 2015. And then now if you go all the way to the far right, they're on the Flex Pro, or sort of the third iteration of it, that was most recently approved a little over 2 years ago. And each iteration is, of course, slightly better than the last, making it safer, easier to deploy, easier to recapture, and allow for better, lower risk issues and higher success rate. The purpose of the Watchman, and we'll get into that, why do we use Watchman? It's to get patients off of blood thinners, right? And the purpose of this slide is to get you a sense of the goal is to get off of those anticoagulants that I talked about, Xarelto, Rivaroxaban, and Pradaxa, and essentially to try and get on just a baby aspirin, which is a huge benefit in the long run for the right patient. And we'll talk about briefly what that means. Briefly looking at the data, this is just to show the history of the device. It's been around for 25 years, and you can see the data around it is fairly prolific. Lots of research around this device. The initial device, or the studies that laid the groundwork for this, showed that it's as comparable to warfarin. It reduces, if you look on the left side, it reduces the rate of disabling strokes, and it reduces all-cause mortality. What that means is stroke, heart attack, or death. And it's shown to be relatively effective and comparable to anticoagulation. If you continue to look at some of the more recent trials, you'll see that the success rate of this procedure is 99%. That's pretty impressive. So of the 400 patients they tested this on, 395 had it done successfully. The other 5, for various reasons, were unsuccessful. But 99%, I would say, is pretty fantastic for any cardiac procedure. The safety of this procedure also pretty phenomenal. Less than 1% risk of any serious problems. What does that mean? Serious problems include stroke, all-cause death, fluid or blood collection around the heart, what we call pericardial effusion, or the embolization of the device. And of all of these patients who had it, 2 had ischemic stroke of the 400. And so to put that into context of other cardiac procedures, this is impressive. Not a lot of cardiac procedures can have this level of success with this level of safety as well. And if you continue to look, you'll see that in the long run, the effectiveness of occluding that is nearly 100%. 98.8% success rate, high rate of coming off of that blood thinner. So overall, it does what it's intended to do. It can occlude the part of the heart that can cause cardioembolic stroke and do it in a safe way to get patients off of blood thinners. And then a few more data says a lot more of the same. There's just more proof here that low risk of stroke, low risk of problems, high risk of success, or high likelihood success rate here. How do you find the right patients for the Watchman device, right? That's the big question, is who would benefit from this device? Because we know it does well, and we know it's got a low rate of risk. Who benefits from this? Ideally, the patients who need a Watchman, number one, they must have AFib, right? Because this is meant for patients with atrial fibrillation. Number 2, they are at increased risk of a stroke. That's based on what I mentioned, that score called the CHADS-VAS score. So if they have a certain risk of stroke, of course having AFib, and the physician thinks that these patients are suitable for short-term anticoagulation. Why is that important? Immediately after that procedure, people do need blood thinners, like those Eliquis and the oral anticoagulants, with the intention of coming off of it in the long run. But they're deemed safe for short-term duration of anticoagulation, but in the long run, they're considered to have a high risk of a serious problem if they take a blood thinner. Right, so what are considered high risk for bleeding? Things that may already come to mind. The most common ones are bleeding from the gastrointestinal tract or GI bleeding, strokes, disabling strokes that cause bleeding, spontaneous bleeding in other places. Other issues that people may benefit from Watchman, patients who don't want to take an anticoagulant. That's enough of a reason nowadays to move people towards considering a Watchman. People who can't or aren't compliant or adherent to anticoagulations because it's a daily medicine, they can't take it regularly, it conflicts with their other medicine. People who are at high risk of falls, so generally older people, as we get older, all of us stumble, but the younger folks hopefully can catch ourselves. As we get older, we're not able to catch ourselves as much. So a high risk of fall is enough to consider this device. In terms of insurance coverage in America, you have to have a certain risk score for that stroke, right, with the CHADS-VASc. You have to be okay for blood thinner in the short terms, and you need to have a two-physician conversation, two different doctors who say, yes, this person would benefit from Watchman, to allow for insurance to pay for it. So in summary, right, I said a lot of things, but in summary, the Watchman is essentially an effective procedure at the high success rate, low risk of problems in patients who have atrial fibrillation and have a risk of stroke related to atrial fibrillation. Now, in those patients, particularly those that can't handle blood thinners, because that's what's usually prescribed, whether it's for high bleeding risk, whether it's because they're at high risk of a fall, cannot take medication, or don't want medication, those would be the candidates that would benefit from this procedure, Watchman device. The future of Watchman is, of course, bright. They're trying to continue to expand its applicability. So Champion AF is one of the trials that's going to continue to show that in all patients with AFib, this is the right solution that can even replace anticoagulation. There's other trials that show how you can lessen the duration of blood thinners post-procedure, and the last one to show that even in people who have blood thinners, they might still benefit from Watchman. So continuously expanding area here. I kept it brief. It was a quick whirlwind, but thank you.
Could you drop the Watchman into the left atrium instead of the appendage?
That's a great question. Janab had asked, can you drop the Watchman in the left atrium? It's specifically designed for the appendage. The reason you would not want to drop it in the left atrium is there's a concern that if it can embolize and cross over to the valve, that's a big problem. It can lead to other additional strokes. So it's specifically focused for the left atrial appendage. The likelihood of that device dislodging and going into the left atrium or elsewhere is very low, as some of the research had showed, almost 0% in some of the recent trials. So specifically focused on just the appendage. Thank you, Janab.
Sorry.
Yes, go ahead. That's a great question. So the question was, in patients with atherosclerosis, is there a chance of plaque developing around the device once it's implanted? So all of the recent data shows that the highest risk, or the most common complication, not common, I would say less than 1%, is the risk of blood clot formation around the device. Because it's inside of the heart and the heart is endothelialized, it's very rare to develop plaque on the endothelialized surface of the appendage device. Clot does happen. It's very rare. It's not clear why it happens. Some thought is it's related to minor leaks. When you put the device, there's a minor less than 5 millimeter leak around the appendage or the device that causes clot formation, but plaque is not typically common. I'm sorry, one more time.
Point.
Okay, if I understood your question, you're asking what is the follow-up after this procedure specifically? Is that right? So the procedure itself, usually 3 visits. One pre-implant to see, and sometimes what we do is a transesophageal echocardiogram or an echo to look at that left atrial appendage. The second is during the procedure itself. The third is typically about 45 days after for that procedure to make sure it's well seated and there's no leak. At that point, usually you can drop or discontinue the blood thinner that a patient is on. And then long term, in terms of if you're following with a general cardiologist or primary care doctor, once that device is well seated, it's sort of a part of your heart. There's no need to continue to monitor it if the first echo at 45 days and even a little later at 6 months is fine. So honestly, once annually is fine. I'm sure they're following up for other reasons as well if they have this device.
Thank you so much. So I have a general question. Appendage devices are great from reducing, stroke risk in patients who can't take anticoagulation. You shared one brief data point about end of the at a 1 year mark, right, sort of reduction in stroke, where you can argue that people are still protected from an anticoagulation standpoint, from that standpoint. Is there any longitudinal data, 5 years, 10 years, with just an appendage device without anticoagulation that reduces the stroke risk significantly?
Absolutely. That's a great question. I skimmed over a lot of that data, but if you look at this slide here and some of the recent data on that, we'll elaborate on that. If you look at this history of the device here, right, the initial trials, the landmark trials, were the first few on the left side, the PROTECT AF in 2005 and the PREVAIL trial in 2010. So if you follow that data out now, and some of that has been developed, so we're talking 15 years out now, those patients that are on anticoagulation, no longer on anticoagulation, just on aspirin, for example, are doing very well. And the risk of stroke is equivalent to that risk of stroke in a patient who is taking anticoagulation. So that's an important point that you mentioned, that the Watchman device in many ways replaces the anticoagulation, but it doesn't necessarily decrease the risk any further. That's the data shows so far. At least that's what also the general consensus is. What it does is it does replace the need for anticoagulation in patients who are at risk of bleeding. Right? So that's the particular population we're thinking about. Thank you.